I also don't know what that will do with lecture capture, guys. So I'll try to go extra slow for that reason. So audio record if you can. I will hook my lecture capture off because that part is something that's working. I can't even, okay, it's recording. Can't tell you for sure what we're going to get, but it's recording. We are, in addition to all that, going to skip around a little bit because the first section, these are some slides I inherited, talks about self-concept, and that is important to sexuality, but I, for time reasons, want to get to the sexuality stuff at the end first, and then we'll come back to these. There's time for that. So, flip over. Start with development of sexuality. Is the first slide I want you to start with. If you guys that have them in front of you will tell me how many pages next to each book. It's on the 4th page. Okay, so it looks like it's about the 4th page in your guide. Somewhere in there. 266-ish if you have numbers. I don't have numbers all the time. These do actually, though. Okay, development of sexuality. So, starts in adolescence when people are about 12 to 18 years old. Primary and secondary sexual characteristics develop. Stillwater, what are primary sexual characteristics versus secondary? Do you know what the difference is? Tongue, do you guys know what primary is? Primary is more, not so much the time frame they develop in, because you're right, those things develop first. Primary is the actual sex organs themselves. Those are the primary sexual characteristics. So things that change about the sex organs are the primary ones. Secondary ones are the other kinds of maturation that occurs as someone enters adolescence. Typically, these people are going to have some irregular menstruation and dysmenorrhea. They may begin to initiate sexual behaviors. Masturbation is common in this age group. They're going to start developing relationships, start experimenting, working on developing their own sexual identity. They're at high risk for pregnancy and for STIs, what's STI stand for? Enid?
Sexually transmitted infection.
We may just not be able to hear
you. Yes, we can. Go ahead and tell her again.
Sexually transmitted infection.
Right, so that's kind of the newer term. Instead of sexually transmitted diseases, we now call them STIs, sexually transmitted infections, because that's what they really are, they're infections. So they're going to, of course, be at a little bit higher risk because they're doing all this experimentation, not necessarily, as we get later in life, we tend to statistically be more likely to be in a monogamous relationship, so we're exposed to the same person repeatedly. Not totally without risk, but less so than during adolescence when people are typically experimenting and often have shorter term relationships and more partners. So what kind of nursing actions go along with that? These people need information about body changes. What should they expect so that it's not frightening to them? Irregular menstruation during this period can lead to embarrassing accidents. We just don't, it's frozen, like the system. They can hear me. And I turn on lecture capture, I don't know if I'm going to get this. You can get here. You want to help them recognize the early signs of menstruation, then discuss options for how to deal with it. Okay. Teach good menstrual hygiene. They need to be frequently changing pads and tampons because those things are great mediums for bacterial growth, other microorganisms. So they need to be changed frequently. They don't just naturally know that. You got to teach them that. You also want to teach them tips to help with dysmenorrhea, such as ibuprofen, heating pads. Keep in mind that teens probably need this information, but they may be hesitant to bring it up and ask for it, especially if they've got a parent in the room. So you want to offer the information, offer the opportunity to kind of take advantage of private moments to visit with them and see what information they might need. Peer groups are going to have a great influence on them, developing sexuality, developing gender roles. Dating during this time period kind of helps them prepare for adult roles and relationships. Their parents are greatly going to influence their values and beliefs. You need to talk to them about contraceptives, and you need to talk to them about precautions against STIs. STIs are the most common bacterial infection among teenagers, so they need to know how to prevent them, what they're gonna look like if they get them, and we need to help them know how to seek treatment, because in some cases, even some STIs that are relatively easily treated can cause major long-term issues if they go untreated. So we wanna make sure they understand that they need to get treatment if they start to see those signs and symptoms. Can you guys still hear me at the other side? He's rebooting things here.
Yes, we can, it's still
Okay.
work.
Yes.
Good deal. So next, young adults. This talks about people 18 to 40. Sexual activity is common in this age group. They're typically establishing their lifestyles and their values. Homosexuality is often established by the age of 25. And the couples begin to share financial obligations and household duties. What? Okay, well, that's kind of what I guess that I can call it. I swear I didn't know. They're often concerned with normal sexual responses for themselves and their partners. Most people form intimate long-term relationships with a partner during this stage. Some don't form those relationships until later adulthood. Some never form those relationships at all. Problems can occur because of differing expectations and responses in sexuality between males and females. This is actually more of a problem in heterosexual relationships. Gay and lesbian couples tend to be a little more on the same page as far as their expectations and don't often have those same issues as much so as heterosexual couples may. They need to be communicating about wants, needs, desires, and kind of try to get on the same page, help them do that. They also need info on family planning and continuing STI protection. Next, middle adulthood. So, middle adults, ages 40 to 65, need to understand that their perspectives about sexuality may change over time. Middle adulthood may lead to physiological changes that are going to affect sexual functioning, things like menopause. They will often have decreased hormone production during this period of time. Menopause typically occurs between the ages of 40 and 55. It occurs because ovarian activity declines, continues to decline to become irregular until it ceases completely. Some of the signs and symptoms we see along with that are listed on your slide: hot flashes, but also chilliness, atrophy of the breast, decreasing metabolism. It's another section later that talks about menopause we may touch on while we're here. Periods are often irregular. It can be an emotionally confusing time for people. Not being able to have kids anymore may be emotionally hard on some people. For other people, that may be a freeing kind of thing that makes them more comfortable with sexuality. Talks about hot flashes, being chilly, breasts become smaller and less dense. Metabolic rate further decreases, often leading to weight gain. They may suffer with insomnia and headaches. Osteoporosis increases after menopause, so they need to be especially careful about supplementing and about fall prevention. I don't know, we've talked about this before. Is it further on this? One of the things for females that it causes often because of the decreasing hormones and other things is vaginal lubrication and elasticity decreases. So they may need to use water-soluble lubricants to offset those effects. One of the concepts we want to get out of our mind and the points of this lecture is that physiological aging is not a reason that people need to stop having sex, basically. And so they don't just reach an age where you ignore those things. So you continue to help them achieve whatever it is that is, appropriate sexuality for them. Continue to help them find ways to get there.
Mrs. Haig,
Yes.
since they don't have a visual prompt yet, they're asking you to slow down just a little.
Okay, I can do that.
Thank you.
We're working on it from this end. Tell me what parts they need to go back over, and I will. The age is on the slide. Hormone reduction, some of the symptoms. I guess the thing that's not, they talk about metabolic rate. Decreased metabolism is on there. Insomnia and headaches are not on there if you want to pencil those in. Osteoporosis.
Are we at late adulthood or middle adulthood?
Middle.
Oh, we see you.
And then the vaginal lubrication and elasticity decreases, so they need water-soluble lubricants.
Mrs. Haig, we can see you now if you want to try to send your PowerPoints across.
They won't let me yet, sorry.
Okay.
I would gladly send my PowerPoints instead of me if that was a possibility, as soon as you will let me. This stage may affect their self-concept. Okay. Do you think it's lecture content and it started over? We can talk about that aspect. Well, it was trying. Only 11 to 40. So it should be fine. Okay. Gibberish. Okay. Can you guys see that, Mr. Baird? Do you see slides now?
We do, but we see the wrong ones.
Well, right, I'm getting there. Oh, you're right, they're paid slides. Where are you? Wait, did I load the wrong lecture? I might have. That's not helpful, is it? Okay, this one's
That was really how you say it? Oh my goodness. Thank you.
yeah, better.
Everyone says that. They sound really loud to me.
Skipping over, there's adolescents. It pretty much looks exactly like what yours is. There are a couple of changes, but I'll tell you about those. Young adults and middle adults. Does that look right now? We good? Okay. So these changes in middle adulthood may affect self-concept, body image, and sexual identity. They may need help adjusting to new roles in their relationship, learning to direct their energy towards other ways of pleasing their partners. And they need to remember to focus on the positive aspects of the relationship, not outside of just sexuality, as those physiological changes in aging occur. Older and late adulthood. This is people who are 65 and older. Sexual activity continues, it may be less frequent. Like we talked about, physiological changes may alter sexual relationships. Women, vaginal secretions continue to decrease, breasts atrophy, men are going to produce fewer sperm, and they will also have increased time to erection and to ejaculation. Many older adults continue sexual activity, but they may need to plan ahead more. Allow plenty of time for the changes in response and refractory times. Utilize water-soluble lubricants to help with the changes in secretions. They may even need to plan ahead and take NSAIDs or Tylenol or kind of try out different positions to alleviate any physical discomfort that may go along with sex at this age. Other couples may need to redefine what sexual activities are to adapt to the physical changes, kind of define it differently, hugging, romantic gestures, other things that can contribute to that intimacy without actually being sex, if it's a problem for them. Older adults may struggle with a lack of privacy if they're residing in a group living situation like assisted living or nursing home facilities. So it may be hard for them to find opportunities to have sexual activity if they're living in those places. So we want to make sure that we respect our clients' privacy in their rooms, in their spaces, so that they can continue that aspect of their personality. Common misconceptions about sexuality. Number one, that men over 70 have erectile dysfunction. The truth is that ED is not an age-related issue. It can occur at any age. It may especially be related to diseases or medications. Number two, that masturbation causes mental instability. That is untrue. Masturbation is a common, normal, healthy behavior. Number three, that sexual activity weakens a person. There's no evidence that sexual activity weakens a person. Number four, that orgasm increases pregnancy chance. There is no evidence that relates those two things. So you do not have to have an orgasm to get pregnant. Number five, size matters. What do you have here? I don't even think that's on here. Basically, there's no evidence that size matters either. There's another one on here that's not on your slide that has to do with like that nice girls aren't interested in sexuality. And that's not true either. The more comfortable a woman is in a relationship, the more she can advocate for her own sexual fulfillment. So it doesn't have anything to do with nice or not nice. Alcohol is a stimulant. Alcohol is actually a relaxant and can cause problems. And chronic use can eventually lead to erectile dysfunction. The next one has to do with sex and menstruation, that the idea that sex during the menstrual period is dangerous. There's actually no physiological basis for that. There's nothing that's different about that in terms of safety. Number 8, The only one-way idea comes from the idea that only the missionary position is the proper way for people to have sex. Any position that is pleasurable and acceptable to both partners is their best position. So, as a for misconception.
It's a relaxing. It can
So what are the components of sexual health for our clients? They are their sexual self-concept. Sexual health occurs when sexual relationships are respectful, safe, and pleasurable. Self-concept has to do with how you value yourself as a sexual being. Yes.
The new students have gotten behind, where are you guys? Could you back up just a little bit, or?
Sure. Where to?
Just slow it down.
So are you back on the misconception slide?
Yeah.
Okay. Which one do you have a question about? Or where at?
Started alcohol.
Okay. Basically, the idea behind that one is that alcohol does not make you better at sex or stimulate sex. It actually is a relaxant that can cause problems with sex. Can eventually lead to ED or erectile dysfunction with chronic use. The next one is that sex during menstruation is not dangerous. And the last one had to do with positions, and the primary point of that is that any position that is pleasurable and acceptable to both partners is good. Okay, so sexual health components. Sexual health occurs when sexual relationships are respectful, safe, and pleasurable. Critical components of sexual health are listed on your slide. The first one is your sexual self-concept. Overall, this is how you value yourself as a sexual being. This value determines how much value you give yourself as a sexual being, determines who you will get into a sexual relationship with. So positive self-concept sexually encourages development of intimate relationships. Negative sexual self-concept may impede that development of intimate relationships. Body image. So your body image is going to influence your sexuality, how you feel about your body. People who feel good about their body are more likely to be comfortable with and more enjoy sexual activity. This can change over time, your body image and the way you feel about your body sexually. If you have a poor body image, you may respond negatively to sexual arousal. Women tend to view themselves compared to kind of the perfect ideal woman shape, which is very culturally influenced. Men tend to view themselves primarily based on size. Next is gender identity. That involves a person's self-image as a female or a male. It's more than just physical. It also includes social and cultural norms, influenced by developmental events, and once established, it is not easily changed. Gender role behavior has to do with the outward expression of being male or female, and the expression that we use about gender-appropriate roles or behaviors. Once again, this is highly influenced by the society and culture that you grow up in. So what are some gender role expectations that are common for Western culture in our society? Let's do, Enid, I'm on you. What do you think?
Women have to make sandwiches.
Women do what?
Women in the kitchen.
Women make sandwiches?
Women make the sandwiches, okay?
Oh,
That works. So Water, what about you?
Men aren't allowed to cry.
Men aren't allowed to cry. That's a good one. Tonko, what about you guys? Men bring home the money while women make the sandwiches. So these are, and that's kind of, I had thrown some ideas out here, like these exist, but we don't typically think about stay-at-home dads or soccer dads, even though those people do exist. And the other thing is, if you go to a Little League baseball game, who do you see coaching? Do you see a lot of women out there? No. So we're moving that direction, and we feel like we've lost some of that, but we still have a lot of those societal underscored, things kind of underneath it. Maybe sometimes we're not even conscious of. So just something to keep in mind. We sometimes look down on other cultures because we feel like their gender rules are excessive and things like that, but we don't always notice what we grew up with, and we have never learned any different then. So just something to keep in mind. Okay, so androgyny is the next one. Androgyny is flexibility in gender role. It's basically the belief that behaviors and characteristics should not be gender specific. Doesn't really have anything to do with sexual orientation, but it's a more reflection of moving away from those gender stereotypes, basically. That women can act however women want, men can act however men want, and they don't necessarily need to follow specific rules related to gender. Do you have a question, Teresa?
Gender role behavior is the outward expression of gender role or
Gender role behavior, outward expression of male or female, and expression of gender appropriate behavior. So sexual health involves both freedoms and responsibilities. So sexual experiences should be freely chosen, including any kind of sexual activities, thoughts, feelings, or fantasies. But at the same time, sexually healthy people are also motivated to be responsible in their behaviors and allow sexual freedom for others. So that's kind of the balance that we have there. Is everybody good with that slide? Okay. Sexual orientation. So sexual orientation involves sexual attraction to others, maybe to the same sex, opposite sex, or both. So number one is gender identity. Western culture is very tied to the idea of two distinct genders. Biologically speaking, though, there are many more graduations between the two. Sometimes gender identity is very clear, in other cases it might be blended. So just like we talk about your client's culture or paying your client as the expert on their own gender identity. Learn to ask respectful questions when you are unsure about how to address someone. Ask if they have a pronoun they prefer to use for themselves. Ask about partnerships rather than marriages. Ask about support persons rather than spouses. We're going to talk more about this later, but the LGBT community has often struggled with poor health outcomes because the healthcare community made them feel marginalized. So if you think about it, the first thing that happens when someone enters a clinic is they're handed a form that's often poorly designed for them to describe their life on, if they don't live in a traditional marriage. So we just have to think about the things we do. And actually, that's kind of our class activity, or in-class activity, we touched on that more today. Basically, you as a generation of future nurses in rural areas can improve on that. You'll have the opportunity to make that better and to improve health outcomes for that community. So, number two, transgender. Transgender is the term for when sexual anatomy contradicts identity. So many times for these people, those feelings start in childhood, and they may often suffer for extended periods of time before they tell their loved ones because they're afraid of the reactions. They may live full or part-time as their chosen gender. Sexual orientation varies. The two are not necessarily related to each other. The next one is intersex. That's when physiological contradictions occur between chromosomal sex, gonadal sex, internal organs, and external genital appearance. So that's an actual physiological contradiction between different parts of the body or different, basically different parts of the body is a fine way to describe that. Cross-dressing. Cross-dressing is an outward expression where someone dresses in the clothing of the opposite sex, typically consistent with their inner identity or gender role. They generally feel more comfortable in that gender clothing. People may engage in that in varying degrees. They may do it frequently or very rarely.
Mrs. Haig,
Yes.
they would like for you to re-explain intersex.
Okay. Intersex is a physiological, I'll read it again, I'll try. Physiological contradiction between the chromosomal sex, like if we tested their chromosomes, their gonadal sex, which that has to do with their actual sex organs, internal organs, like we'd be talking uterus, ovaries, things like that, and external genital appearance. So basically what it's saying is there's some kind of physical discrepancy. So some of these other ones we're talking about more of like an emotional, psychological discrepancy between physical expressions of gender and what I feel is gender. This one is talking, intersex is talking specifically about physical issues that don't agree with each other. Does that make more sense?
Is it like when they're born with like 2 parts, but the inside has like a uterus, so they decide?
Mr. Barry?
Is that kind of like how it is?
I think she's saying that they could have
Yes, she said they did.
but also ovaries.
Okay.
What
But
factors influence our sexuality?
Had a,
So,
daughter.
it's not a big surprise, family is gonna greatly influence our sexuality. That's typically our earliest and most enduring social relationship source. So, it influences our gender identity, they influence our body image, they influence our sexual self-concept and our capacity for intimacy. We often pick up our outward signs of affection from the way our parents interact with each other. We're gonna also pick up views on sexual activity from the things that we hear or expressed in those family relationships. That may be anywhere from that sex is a dirty and shameful thing to sex is a fun and enjoyable part of adulthood. So, and anything in between those two. Next is culture. It's another factor that influences our sexuality. We often get ideas about premarital sex, extramarital sex, homosexuality, polygamy, all those ideals that we have are heavily influenced by the culture that we grow up in. Even which body parts are considered erotic and should be covered in public is culturally influenced. Ideal body weight to be sexy is culturally influenced. Ideas about what constitutes nudity are culturally influenced. An example is that like female circumcision is practiced in some cultures and can go as far as genital mutilation. Americans are understandably horrified by that, but continue to accept or even expect male circumcision. So, even once again, questioning those things that we just grew up with and understanding how they might relate, what our real rationales are behind them. But all influenced by culture. Also influenced by religion. So, religion's going to influence our sexual expression. Religion typically provides guidelines for sexual behavior and the acceptable circumstances for that sexual behavior. In some religions, those rules are going to be broad and flexible. In others, they're going to be very detailed and rigid. A fair amount of conflict has arisen between religious expectations and changing cultural norms about sexuality. Conflicts between the two can often be really hard on individuals and cause a great deal of anxiety and altered self-concept, and even lead to sexual dysfunction when their self-concept of sexuality doesn't agree with the religious beliefs that they were brought up with. Sexuality is also influenced by our personal expectations and our personal ethics. So ethical thoughts and approaches to sexuality can be viewed separately from religion. Our personal views may vary greatly within one cultural or religious group. Many times factors involve age of consent, location, like whether things are happening in public or private, and our sense of whether or not anyone is being harmed in the party, in the group, will often affect our individual views on what's right or what's wrong. Couples especially need to be clearly communicating with each other regarding individual expectations and limits in order to maintain equal decision-making and autonomy in sexuality. As always, an assessment of our own personal biases is most often the first step in providing care for our clients. So let's talk about alteration, altered sexual function, and there's a part of this slide, I'm glad we have it back up for now, that is red. Do you see that? I altered the slide a little bit. It wasn't one I originally made, and when looking, it looked like things were grouped in kind of a funny way. I kind of think those things on your slide might be listed under orgasmic disorders, and really they're pain disorders. So if you want to take a second to fix that and change kind of the way those things are grouped. So many people are going to experience short-term issues during their lifetime with arousal or with maintaining an arousal. For a smaller portion of those people, that'll be a lifelong situation. These problems may be generalized or they may be situational. And oftentimes there are a lot of contributing factors, and it's difficult for us to determine exactly what's contributing to the situation. So altered sexual function, of course, can be influenced by past or current factors. Family influence, like we talked about, rigid rules or negativity towards sexual experiences. Any kind of history of sexual abuse is going to affect sexual function. People may have fears about pregnancy, pain, or sexually transmitted infections. They may fear failure, or they may fear intimacy. Depression can cause a loss of interest and enjoyment. Poor self-esteem or body image is going to affect sexuality. Sometimes relationship problems are actually expressed as a sexual difficulty, especially if people are starting to feel like a sex object and there's not a lot of communication within the sexual relationship. Health factors are going to affect sexual function. The changes that may go along with pain or surgery or STIs. Medications. Some medications are going to inhibit sexual function, others may enhance it. So, but these are kind of the factors that you need to be aware of as a nurse, and we'll talk more about this later, but it's really important that you teach your clients, especially if they're going in, that you get them to express their fears maybe before a procedure about how it's going to affect their sexuality and address those ahead of time. Tell them, what may or may not happen, what they need to worry about, what they don't, and try to alleviate some of those things. So the first thing as far as disorders that we talk about is sexual desire disorders. The first one of those is hypoactive sexual desire. What does hypo mean? Low. So it's below average. So it's a persistent low interest or lack of interest in sex. This may or may not be a problem. It's going to kind of depend on whether it causes a disparity within their partnership. If both people have the same level of interest, it's not really a problem. But if there's a disparity, then it's probably going to cause trouble in the relationships. Other people may have a sexual aversion. This is more than just no interest. This is a severe distaste for anything having to do with sexual experiences. So this may lead them to avoid sex entirely. Any kind of exposure to sexual situations may trigger anxiety cycles. Then we get down to specifically arousal disorders. Typically this in females, a lot of times this causes a lack of lubrication, which will cause pain and discomfort during sexual activity, which is going to further contribute to them not really being that interested. For men, we typically see erectile dysfunction. Typically this is related to either getting an erection or maintaining an erection. An older term that was often used for this is impotency. That's a very negative connotation. It's basically the opposite of having power, so it's kind of in itself, that word, it has a negative connotation to it, so you don't want to use that word. Use ED or erectile dysfunction instead. For both, an arousal disorder can also just be a persistent lack of subjective excitement or pleasure in the absence of the physiological symptoms. So maybe they go ahead and have the physical symptoms like they're aroused, but they don't get that sense of arousal and pleasure to go along with it. So that's another type of arousal disorder that can occur in either males or females. I don't know, I think we already touched on menopause. So then under orgasmic disorders specifically, females, what happens for them in an orgasmic disorder is that their sexual response stops before they reach an orgasm. So they get aroused, but they're unable to have an orgasm to complete that. For males, there are two different directions it can go. They can maintain an erection, but have trouble ejaculating, have difficulty actually completing the ejaculation. That's the less common. Typically what you see more commonly is they have a rapid ejaculation. It's hard to define and give you an exact time frame on what's a rapid ejaculation. It kind of is whatever it is to them or to the couple. So if the man feels like it's too soon, it's too soon, or if the couple together feels like it's not lasting long enough, then that's where that diagnosis comes from, not so much a specific period of time. Like we talked about with the other sexual stuff, if it fits together within their partnership and they're not displeased with it, then it's not so much of a problem, really. It's just when it doesn't, when it's causing them, when it's decreasing their sexual self-concept, that it becomes an issue. Okay, so note your slide changes. Pain disorders are the next section. Dyspareunia is pain during or immediately after sex. Can happen for men or women. Often associated with problems with either lubrication or some other kind of physical problem, like an infection or endometriosis or things like that, or some kind of lesions in the area. Vaginismus is an involuntary spasm of the outer third of the vaginal muscles. So this will make sexual penetration painful or impossible. People who suffer from this usually can actually have orgasms with external stimulation, but any kind of internal examination or penetration is going to is going to trigger those spasms and cause them pain. Vulvodynia is a constant burning localized to the vulva, usually has an acute onset, and can lead to problems, even when they're trying to sleep, stand, sit, all those other things beyond just sexual activity. Vestibulitis is severe pain with touch or vaginal penetration in that area. All of these things, as you can imagine, cause negative impacts to relationships, self-esteem, and overall mental health for people who are suffering from them. And then the next one is problems with satisfaction. So problems with sexual satisfaction can occur even in situations where desire, arousal, and orgasms are all intact. Commonly, these are related to the emotional portions of the relationship, not so much the physical. They may be situational. A lack of intimate but non-sexual touching can sometimes contribute to those situations. Like where you get in those situations where a woman feels like the man only touches her when they want to have sex, but doesn't ever show affection in any other ways. May be related to other relationship difficulties or communication difficulties. Can go on to lead to a further lack of intimacy and problems with connecting with their partner. Depends deeply on the ability to relate with the partner intimately in a mutually pleasing way. So those are kind of probably the important concepts of mutually pleasing. So as long as the partners are okay with what's going on, it's generally going to be okay. It's when there's an unequal balance there that things need to be dealt with. And we talked about menopause already. We'll talk about it more if we get to that very end part. Okay, so assessment on sexuality. We'll look at sexual history, physical examination, and identifying any risks that they may have. So, regardless of the reason for a client's visit, it's important to open the door to those conversations about sexual concerns with all clients, because many of them are going to be hesitant to bring those things up on their own. So, learn how to ask at least one question as a nurse. And it has some wording in your textbook like, as a nurse, I'm concerned with all aspects of your health. You will often have questions about sexual matters. Have there been any changes in your sexual functioning? Do you have any concerns about sexual matters? So just kind of give them an opening so that they can bring those things up. And the more you can normalize it, the easier it's going to be for them to talk about it. So if you can start out with that kind of, people often have concerns about this, so that they understand that they're not the only person who has those concerns, makes them more comfortable. The other thing that helps is being sure that you reassure your client that information they give you is protected health information. So even when they're talking about their sexuality, that's a confidential matter. And you may have to tell them that, because they're going to be a lot more open if they know you're not going to be out in the hall talking about it after they tell you the information. It is, of course, vitally important that you set aside any personal beliefs or opinions and act in the best interest of your client. Your book also gives this suggestion that you start out these questions always with the belief in your head that all people do all things. So if you just start out with the idea that literally nothing that comes out of that person's mouth is going to shock you, then it'll be a lot easier for you to have those conversations and maintain your poker face while you do. So, as far as history, you want to talk about changes in sexual function, number of partners, sexual orientation. There is on page 946 an assessment and review that kind of gives you some specific questions that you can go through with your clients. They may need a physical exam. It's going to kind of depend on your facilities and what their reason is for the visit. Typically, they'll need a physical exam if there's suspected infertility, a sexually transmitted infection, a possible pregnancy, or any kind of reports of physical changes or discharge in the genital region. Then they'll probably need a physical exam. You're going to look for some of those risk factors that we already talked about, other risk factors that might be involved in sexual function, if they have any kind of alterations in body structure, if they've been abused or assaulted. If you might look at their medications, are they on any medications that might be causing impairment? If it's a situation where you feel like their personal sexual values might conflict with beliefs or religion or culture, then you might want to assess for how they're doing with those things. If they've lost a partner, you also want to correct any misunderstandings, misconceptions, like the ones we talked about before. So if you catch them say something, you're going to change their knowledge base. Next, we're gonna move to sexually transmitted infections. That box, I think, okay, there is a box on 937 that talks about the clinical manifestations of these sexually transmitted infections. A lot of it goes on your slides. Be sure that you take a look at that box and get familiar with it. There are a lot of disorders on there. 937, I think. Does that sound right? I'm looking kind of far away, but. Okay, so we're gonna talk through those. So, gonorrhea is the first one on here. For males, that typically includes painful urination, a watery white discharge, and that discharge may be purulent. Which what does purulent mean? Right, like pussy, yeah. For females, they may be asymptomatic with this disorder. Otherwise, they may have some vaginal discharge, some pain, and some urinary frequency. So this is one that may be hard to identify and treat in females because they're kind of vague symptoms and not necessarily super strong symptoms. So, when you think about, this is one of those reasons, I don't know if you've ever, like, as a female, gotten frustrated because you just knew you had a yeast infection, but you still had to go see your doctor to confirm it. This is one of the reasons, because sometimes it is hard that when we start talking about the symptoms of STIs, the symptoms of like yeast infections and some of those things in women are very similar. And so treating it incorrectly can cause future problems, basically. So that's one of the reasons that you may need to go in. You may need to do the physical exam part. The next one is syphilis. So for males, they get what's called a chancre, which is like the actual lesion. For some people, that's just a single lesion. For some people, they may get more than one. But as the initial primary breakout for men, sometimes they'll just get one. Do you have a question, Cassie? Is it on here? Is it on that box? Okay. No, I would worry about what's in that box. Typically, these will be painless on the glans penis. They usually take 4 to 6 weeks to heal. So that's kind of the first stage. So with syphilis, we have 3 different stages: primary outbreak, secondary outbreaks, and then a tertiary stage. So you can see that down on the slide. So that's kind of the primary, like the first outbreak of it. Secondary outbreak is more generalized. So it's going to involve skin eruptions, a low-grade fever, inflammation that leads to swelling of the lymph glands. That one will typically occur 6 weeks to 6 months after that first lesion heals. Tertiary syphilis occurs much later, and it occurs when syphilis remains untreated, and it causes like full body internal organ issues. Affects the brain, affects the nerves, affects the liver, causes major issues. It's kind of off topic, but one of the reasons that we're very careful about research on human studies has to do with a study that was basically done without people's consent a long time ago, where they basically just didn't treat their syphilis to see what would happen. And what happened is they got major long-term effects. And so that's one of the things that led to like having people sign and give informed consent for any kind of research they're participating in. So obviously withholding treatment from someone is an unethical thing to do just to find out what happens. So in females, they're going to have the same kind of sores on their cervix or genital areas, heal in 4 to 6 weeks, and then kind of follow that same progression if they're untreated. They'll get the second stage 6 weeks to 6 months afterward, and eventually develop internal tertiary symptoms if it remains untreated. Next, genital warts. The picture there. We have pictures on all of these. Gives you kind of some signs there. It's the result of a human papillomavirus infection, HPV infection. They will get single lesions or a cluster of lesions. So you've definitely got body image issues there because you've got those lesions that stay. They can sometimes go away, but typically they need to be treated. Once they've been diagnosed, it's important that they understand that the virus doesn't go away completely, so they will be transmissible to sexual partners in the future. It is linked to cervical cancer, so anybody who has this diagnosis will need to keep up with their annual pap smears to detect any cell changes early. Lesions may take months to years to go away, so they cause long-term damage to people's body images and typically their sexual relationships, even when they're treated. We'll eventually get to the fact that the best way to deal with these things is to prevent them. Jen, you have to do this part. It is typically continues to be transmissible, yes. I'm trying to think about syphilis. I think once they're treated, it does not say transmissible. The problem is they don't necessarily get treated. So it's more the long-term effects to that person of not being treated. We're gonna have to do some more research because I wouldn't swear that off the top of my head. Chlamydia. Okay, we're on the right spot. For males, they may get urinary frequency, watery mucoid urethral discharge. Females are oftentimes carriers of this disorder. They typically get a vaginal discharge, dysuria, and urinary frequency. Gives you pictures of a healthy cervix versus an infected cervix. Trichomoniasis. The next one, for males, typically causes itching and moisture, a slight morning discharge, but many males will be asymptomatic with this one. For females, they're going to have itching, redness, and a lot of watery, frothy vaginal discharge. Next one is candidiasis. This is a fungal type infection. For males, it's going to lead to itching, irritation, discharge, and like kind of a cheesy, if you think about, the idea about it, like if you think about like somebody has thrush or has that like kind of white cheesy stuff in their mouth, that might be something you might experience with. Similar, like that will kind of help you think about what this one looks like. So, cheesy material. Females, red, excoriated vulva, itching, thick white cheesy discharge. We'll go on with that one. And I think we've got, maybe two. We've got a couple more of these and we'll take a break. Next one is AIDS, which stands for, because I don't know that it's on here. What does that stand for, John? Acquired immune deficiency syndrome. Symptoms for this one may take months to years to develop after they've been infected. And the symptoms that you will see when they do develop are not actually the disease itself, but are a result of the reduced immunity to other diseases. So what you get is a variety of other diseases that basically take advantage of the lack of immunity. Symptoms that you'll be looking for are listed on your slide, and that's basically situations where you see these symptoms and there isn't another reasonable explanation for them, is where you start looking at them. Heavy night sweats, extreme fatigue, severe weight loss, enlarged lymph glands, persistent diarrhea, skin rashes, blurred vision, chronic headaches, a harsh dry cough, or thick gray-white tongue coating. And like I said, a lot of those don't necessarily group into one specific disorder, but are signs of a variety of things that they will get because they don't have proper immune system so much. Last STI for us today is herpes genitalis. This one occurs primarily, and then it will continue to reoccur over their lifetime. So they have a primary outbreak where they have very painful sores that last for weeks and rupture. Then it will recur at various times during their life. Those episodes are typically shorter in duration, may last from a few hours to 10 days, and are typically more itchy than painful, but they can transmit the disease anytime they have that kind of outbreak going on. So even if they're in a long-term monogamous relationship, they need to use protection with their partner. Okay, before we move to planning, with that, we'll take a snack break or whatever. The set goal is to do what? We want to maintain, restore, improve their sexual health. We want to increase knowledge for our clients. We want to prevent those STIs we just talked about. We want to prevent pregnancy if that's what our client wants, or at least assist them in family planning, whatever direction that is. We want to help them increase their satisfaction with their sexual health. And we want to improve their self-concept as well, because that feeds into the improved sexuality and sexual health. Implementation. The first thing we're going to do is provide health teaching. So when we talk about education, we want them to understand their anatomy, the normal function of that anatomy, any developmental changes, and that's not just puberty, but also what changes go along with pregnancy, what changes go along with menopause. We want to teach them about the effects of any illnesses, surgeries, or medications on sexual function and sexuality. We can teach about Kegel exercises. Stillwater, what are Kegel exercises?
Pelvic floor muscle exercises.
I didn't hear the bottom. I think I got what you said, but yeah. They exercise, I think, did you say pubic core? Is that what you said? Pelvic core, that's what you said. Okay, that works. Pelvic core exercises, and basically they're done by the female by stopping and starting urine stream. It helps strengthen those muscles and can have a lot of positive health effects for them. So it's something that we teach our clients a lot, especially anyone who's childbearing, because it can help decrease the effects of all that extra pressure as the uterus grows. So, good thing for you to know that ties into sexuality. We also want to teach parents how to talk to their kids about sexuality, because many parents have difficulty communicating with their kids about sexuality. So we want to talk to the kids. We also want to teach the parents, and we want to encourage the parents to teach their kids anatomically correct terms. Does anybody know why we want that and talk about it? Tell me.
Because if you use a more than something like not to consider in school, not to start what.
Exactly. She's got that exactly right. When we teach them kind of those cute terms that are okay to use in public, if something bad happens to that, they're going to have difficulty reporting that to anybody. Or if they, like, just to use an example, if you call it their flower or something, and they tell their teacher something that happened to their flower, that teacher's not going to think a thing about it. But if they've learned proper anatomical terms and they express that to a grown-up, they're going to think about it and deal with it. So it is important that kids learn those things and what the proper names are for them so they can communicate any kind of abuse that occurs. We also want to prevent those myths and misconceptions and misunderstandings that we talked about too as far as education. The next section is self-examination. Your book talks about breast self-examination and testicular exams. Here's the thing, it's actually not recommended necessarily anymore. Several large trials basically told us that it didn't help with survival rates, and it caused us to do a lot more procedures on people who didn't need them, basically. So we don't actually teach that breast self-examination. Doesn't mean that you're gonna have to go with whatever your facility is. You may work for a provider who still teaches that, but the overall evidence-based practice recommendation these days is that that's not something that we need our clients to do, because the outcomes don't actually improve based on it. Similar idea for men as well. The U.S. Preventative Services Task Force and the American Cancer Society. Basically, the U.S. Preventative Services Task Force no longer recommends testicular exams, and the American Cancer Society just says to discuss the value of your PCP. So, don't necessarily teach those exams. You do still want to teach your clients what they would report to, however. So, like if they had a sudden breast discharge, if they saw a change in the breast, they suddenly became less equal in size, they had some kind of dimpling, if a male notices a testicular lump, you still want to teach them those things to report, but we're not necessarily teaching them to do those monthly self-exams like we used to. We also want to talk about responsible sexual behavior. So what is responsible sexual behavior? That includes family pregnancy planning, prevention of sexually transmitted infections, and avoiding sexual harassment and abuse. So as far as STI prevention, STIs are on the increase, basically, because we have increased sexual behavior and number of partners in general overall in our society. So we have a lot more STDs now. STIs. If signs and symptoms are noted, they need to seek treatment immediately. You need to encourage the importance of treatment to people. Some people feel shame or guilt. They're hesitant to go and seek treatment for these disorders, but some of their STIs can be easily treated but will lead to complications for their lifetime if they're not treated. So it's important that you teach them the signs and symptoms and make it easy for them to get treatment. Tell them how to seek out that and let them know that they're common and they shouldn't feel any shame or guilt over them. We want to remind clients that condoms provide STI protection even if other contraceptives are in use that don't offer protection. So we also need to keep in mind the need for protection during oral sex as well, and there are products that people can use to help protect with that too. Prevention of pregnancy definitely applies to education of adolescents, but it's an important part of planning for couples and families throughout childhood years. It's also important that for any childbearing individuals that are taking certain medications that can have effects on fetuses and pregnancies, so we want to be educating those clients when you see that they're taking medications, make sure they're aware of the risks of